Hello, it's Beth Wright providing you a podcast for NUR 237, Unit 2, Chapter 35, and we're going to be talking about drugs used for peptic ulcer and acid reflux disorders. And so I've listed your exemplars here. You have your antacids, and then you have your Helicobacter pylori agents, and your histamine receptor antagonist, histamine 2 receptor antagonist, that should say, and your protein pump inhibitors, and your adjuvant medications to treat peptic ulcer and GERD. Okay, so let's talk about GERD. It's a common condition with folks. You probably have been giving medications to help treat this with your patients in clinicals. And so when we think about the GI system or the gut, we know that the normal body function involves gastric juices being there to help digestion of foods, and it stimulates specific hormones and chemicals to help with this. So one chemical is our hydrochloric acid that helps break down foods, and it also activates pepsin to help break down protein. Mucin is an enzyme that helps protect the stomach lining. So when we have problems with too much acid buildup, we've got a barrier issue with the stomach. So, our stomach lining is considered a barrier that helps protect the stomach from all of these enzymes and chemicals, the hydrochloric acid from breaking down. But there are things that get in there and break that barrier. Things like medications like aspirin and ibuprofen, corticosteroids, our diet, alcohol, too much spicy foods, smoking, physiological issues such as an incompetent lower esophageal sphincter, infections. So things like that can cause problems in our GI tract. And when we have GERD, when someone's diagnosed with GERD, that is the regurgitation, meaning the backflow of gastric contents into that esophagus and exposing that esophageal mucosa to gastric acid and to the pepsin. So symptoms are heartburn, regurgitation of acidic fluid into the mouth, pain on swallowing. And again, our causes can include that incompetent lower esophageal sphincter. Now, things that can cause that incompetent lower esophageal sphincter, which leads to the GERD or the reflux, can be fatty foods, chocolate, fluids such as alcohol or caffeine, medications such as beta-adrenergics, calcium channel blockers, nitrates. Gastric distension can also cause issues with that lower esophageal sphincter. Cigarette smoking and a recumbent posture. Now, when we talk about peptic ulcer disease, that is an imbalance between the cell destructive and cell protective effects in that stomach area. And again, the barrier breaks down and it is exposed to the chemicals, the gastric acid and the pepsin, which results in an ulcer. Acetylcholine, gastrin, and histamine stimulates gastric acid production, so that again can lead to further ulcer development. We know that pepsin digests protein, but it can also digest that stomach wall as well. And H. pylori or Helicobacter pylori is a type of ulcer in the stomach where the barrier breaks down, and we have an infection basically that impairs that mucosal function. And so that's a very common type of condition in the stomach that has to be treated, and we'll talk about the treatment for that in just a second. Okay, I've got a pictogram for you of peptic ulcer disease, and you can see there's several different types of ulcers that can happen: gastric ulcers, duodenal ulcers, and stress ulcers. And of course, the common risk factors for these are the H. pylori, which can definitely lead to the ulcers, alcohol smoking, gastritis, and so you see signs and symptoms of each of those types of ulcers. The gastric ulcer, weight loss, normal or hyposecretion of acid, pain, a half hour to an hour after meals, vomiting, and eating may actually increase the pain. Stress ulcers are physiological stress a lot of times, and sickness. Folks that are in the hospital after they've had surgery, or if they're in ICU or have some kind of serious condition going on, many times you'll see physicians order treatment for prophylactic use to prevent stress ulcers, because it's very, very common. We can have Cushing's ulcer with brain injuries, or we can have Curling's ulcers with extensive burns, and those are common to see. And then the duodenal ulcer, pain 2 to 3 hours after meals, and food may actually decrease the pain. So one way to help distinguish the difference of those ulcers. So let's talk about medications that are used to treat these different conditions. So one of them is antacids, and these antacids are alkaline, and that's meaning that they raise the pH level of the stomach acid. They can also stop the conversion of pepsinogen to pepsin, so that being involved in that H. pylori infection. We have aluminum, magnesium, and calcium compounds that make up the different types of antacids, and the aluminum base may lead to hypophosphatemia and osteomalacia and constipation. So I want you to think about, if you had aluminum, we all know what aluminum foil is, and we had that inside of the system. Think about what that would do. That would definitely cause constipation. Your magnesium based can cause diarrhea and hypermagnesemia, and it is contraindicated in renal failure. So if you think about these, and we'll talk a little bit more about the calcium type, but if you think about the aluminum kind causing constipation and the magnesium base causing diarrhea, many times what you'll see are a combination of both of these products within an antacid, and that can help reduce the GI symptoms of them. Calcium base can cause hypercalcemia and acid rebound, so hypersecretion of gastric acid. Gelusil, Melanta, and Malox, they are your combination aluminum and magnesium. Melanta also has the simethicone, which is an anti-flatulent added to medications. Alginic acid, alginate, thickens and produces a foamy layer over top of the gastric acid and to prevent backflow. And so that's Gaviscon. So we can talk about each of these. And in general, antacids bind with many medications or may decrease the absorption of many medications by increasing that alkalinity of the stomach. So other medications should not be administered within 1 to 2 hours of antacid administration. Antacids are usually given 1 hour after meals. This can be a challenge, as acids also have a longer duration of action if given after meals. To avoid constipation or diarrhea from antacids, they can be combined with the two, magnesium and aluminum. Okay, and antacids with the word carbonate at the end or in their name will release carbon dioxide when binding with acid, causing bloating, because you know that's a gas. We know that simethicone, it can be added, and that will decrease gas bubbles in the stomach, relieving the bloating. Liquid antacids usually work better when because they're already dissolved. Remember to shake them very well before administering. It should be measured as well, not chugged. I've seen people do that before. Just open up the cap and chug the medicine. Chewable tablets are available for many, and those for folks on the go. And they need to be chewed thoroughly and followed with a glass of water, because that helps with improving the antacid action. And quick dissolving tablets are also available. Aluminum products we know can cause constipation. Long-term use can cause hypophosphatemia and osteomalacia due to the aluminum combining with phosphates. Amphigel is an aluminum product, and it can cause phosphate depletion, except for aluminum phosphate. So the ones without phosphate can cause a depletion in your phosphate. A lot of times you'll see physicians give these products to patients with renal failure with the purpose of helping lower their high phosphate level. Magnesium base have a neutralizing effect and rapid onset. Again, they can cause diarrhea and hypermagnesemia. A common one there is your milk of magnesium. Contraindications with the magnesium ones would be your patients with renal impairment. Okay, and then our calcium types have a rapid onset, and they can cause hypercalcemia and hypersecretion of gastric acid at the rebound effect. They tend to cause constipation also, so think, calcium starts with the C, and they can lead to constipation as well. A common one here is calcium carbonate, TUMS. Because of that carbonate, it can cause bloating. We have to be sure to look at your F&E units with all of your electrolyte issues with the use of antacids. We've seen calcium carbonate also be used as a diet supplement, but since patients needing it as a diet supplement also needs vitamin D, because that helps it be more palatable. Aluminum hydroxide and magnesium hydroxide is your Gelucil, Malanta, and Malox. And I think that concludes what we want to say about that. Okay, here is a pictogram with your aluminum hydroxide. It talks about not feeling right, pain in the stomach, and it says, the doc says you need Amphigel to neutralize your stomach acid. Take the Amphigel with magnesium to prevent constipation, and watch for fluid retention due to increased sodium intake. On the right side, when agitated, I burn. It's the stomach talking, and when I burp, I bring up stomach stuff. And so he's given the Amphigel to put out the fire. Watch for fecal impaction, intestinal obstruction, and hypophosphatemia. And you can see the little doggy. I feel that way when I eat ants. Oh, I like these little pictograms. Corny, isn't it? Okay, now let's talk about H. pylori. So this is a cute little picture, I think. So the H. pylori, it talks about it's a gram-negative rod, wicked little stomach infection there, and we got to treat the bacteria when we have that. And the thing you can see there, it's a common precursor of gastritis and peptic ulcer, and can be a risk factor for stomach cancer. So you can see the little H. pylori urinating into the crater of the stomach there, the ulcer, and it's just, showing the penetration there. It's getting through. And ammonia also neutralizes acid pH, which allows organisms to live in the stomach. So the treatment, you can see there, is going to be a regimen of 3 different medications, and we're going to talk more about that here in a second. So here are our agents: amoxicillin, clarithromycin, metronidazole, or tetracycline, along with a histamine 2 receptor antagonist, or a protein pump inhibitor. Now, bismuth may also be added. That's your Pepto-Bismol, and it helps inhibit H. pylori by disrupting cell wall and increasing mucus and bicarbonate. It inhibits pepsin activity and lines the ulcer crater. So again, we have to treat the bacteria and try to restore the lining of the stomach with H. pylori to keep the ulcers from forming. There has to be 2 different antibiotics that's given, and I will tell you the metronidazole, which I got a pictogram for you a minute ago, that's coming here in a minute, is quite the medicine with different serious adverse effects. So we've got to be sure to teach. Also, tetracycline is one of the medicine. All of our medicines have serious adverse effects, so we got to teach about that. Now, the bismuth has an antibacterial effect, which is great, and it increases secretion of mucus and bicarbonate, and it inhibits that pepsin activity. So it's a real big help to take, and it's pretty cheap. Be sure to tell people who are taking Pepto-Bismol or Bismuth that the stools will turn dark color, and so it's one of those side effects, but it's not a harmful side effect. Also, the H. pyloric agents are now provided in a combination pack, which can help with the expense, I guess, of buying three. Instead of buying 3 different products, you can buy 2 or buy 1. One of them is a Prep pack, and that's amoxicillin, clarithromycin, and the a PPI, the lansoprazole. Helidac is peptoflagyl and tetracycline, and Pylera is Pepto-Bismol, flagyl, and tetracycline. And flagyl is the trade name for the metronidazole. Okay, here's your pictogram for that. Metronidazole, nausea, vomiting, stomatitis, headache, dry mouth, fatigue. You can see all of the little bugs there that it's used. And we do see this used quite a bit because of C. diff and H. pylori and other things that it helps take care of. The big thing we got to teach the patient is no alcohol products, none whatsoever. Because they will have a reaction. And I heard one guy talk about that he actually went into a psychosis because he didn't know about the alcohol thing. And he had a psychotic reaction to the medicine. So we definitely got to teach about that. Okay, histamine 2 receptor antagonists are here, but I first want to talk to you a little bit about histamine. So, you know, histamine is that chemical that's released when we have tissue injury or some kind of allergic reaction, and it's a biggie in our inflammatory response. And what histamine does is it contracts the GI tract and the uterus and bronchial areas, and it dilates and increases permeability of capillaries. It also dilates cerebral vessels and stimulates sensory nerve endings to produce pain and itching. It also stimulates gastric acid secretion. So, hence, histamine 2 receptor antagonist helps with that part of it. Okay, now antihistamines are your H1 receptor antagonists, and you studied about those in your very first pharmacology class. But here we are talking about our histamine 2 receptor antagonists that prevent or reduce secretion of gastric acids. So one dose stops secretion for around 6 to 12 hours. They relieve heartburn symptoms by blocking histamine type 2 receptors, and they can begin working within an hour, so they act pretty fast, but they don't provide the immediate relief like an antacid. They can continue to work in the body for up to 12 hours, and the H2 blockers can work preventatively against heartburn. But again, they don't last a full 24 hours. We got to use in caution with children, pregnant women, older adults, and impaired renal and hepatic function. And cimetidine, ranitidine, and famotidine are your exemplars for this. So clinical indications are for prevention or treatment of peptic ulcer disease or GERD and esophagitis. You'll see it used for GI bleeds due to acute stress ulcers, Zollinger-Ellison syndrome, and that's a rare tumor in the pancreas, stomach, or the duodenal area that is a gastric secreting tumor. And so you'll see these medicines used for that, and of course for heartburn. So our H2 receptor antagonist we'll talk about first is our cimetidine. But one thing I want you to notice is that all of these do end with IDINE. Okay, so that's one way to remember it. These are all now over-the-counter agents that reduce secretion, acid secretion in the stomach, and allow acid-sensitive ulcers to heal. The downside is they can cause diarrhea, muscle pain, rash, drowsiness, and dizziness. So cimetidine was the very first H2 receptor antagonist developed. And, you know, usually those first drugs in the class that have been developed have the most side effects than drugs developed later. So, you know, basically they go back to the drawing board to try to develop something a little better. And that is true with cimetidine. It has a lot of different side effects. It produces anti-androgenic effects such as low sperm count, impotence, and gynecomastia for males, and galactorrhea for women, meaning breast milk can form and come out. It can also cause confusion. This is more likely in our elderly patients and those with any kind of renal or liver disease. When given IV, especially, it can cause problems. It is the only drug in this class that impairs the metabolism of many drugs in the liver. Because of the special liver enzymes needed for drug metabolism, that's why it happens. So since the drugs aren't being broken down, they will have an increased effect when given with cimetidine. So we got to be really, really careful about that. Cigarette smoking will keep cimetidine from working as well overnight, and we should definitely avoid it with pregnancy. Okay, ranitidine has fewer drug interactions, and the famotidine is more potent, so a lower dose can be given. Also, they have less drug-drug interactions, which is good. All of these, again, are available over the counter. This famotidine can be given IV, push, or a bolus. You need to administer it over a 2-minute period. Adverse effects are constipation, diarrhea, headache, muscle ache, fatigue, skin rash, delirium, coma, depression, and fever. Again, the drug-drug interactions, there's a slew with Tagamet. Ranitidine can decrease absorption of diazepam and increase the hypoglycemic effect of glipizide that's used for diabetes. And you got another pictogram here. The Wrestling Federation presents H2 receptor antagonist smackdown. So it talks about Zantac and Tagamet, that being your trade names, versus painful gastritis or ulcers. And you can read on there. As far as decrease in stomach acid may increase growth of candida and bacteria in the stomach. Okay, next is our protein pump inhibitors, and These meds bind with the protein pump and inhibit the protein pump from releasing gastric acid. So for GERD, it usually takes 1 to 2 weeks. The esophagus heals, and they may have to stay on the med for a maintenance dose. Now note that the ends of each of these names, esomeprazole, lansoprazole, and pantoprazole, and omeprazole, all of them have the prazole at the end of them. So that's a good way to keep those in your head. This class of drugs blocks acid production and can not only heal damage by acid, they relieve symptoms and can eradicate the cause of the majority of gastric ulcers, such as H. pylori, when it's given with those antibiotics. Now, these should be taken on an empty stomach. No crushing or chewing. We need to swallow whole. All except Prevacid comes in a capsule with granules. Can be put in water. Don't crush the granules for the capsule. Now the capsule with the esomeprazole can be opened and put in water. Now these drugs come as capsules with little teeny tiny balls in them, and it can be difficult to get those little teeny tiny balls down an NG tube or feeding tube, so we need to consult a physician whenever that situation occurs and see if we can get the medicine changed. Omeprazole, we do not need to substitute a 2 20 milligram pills to equal a 40 milligram dosage that's ordered. We need to call the pharmacy and tell them to send a 40 milligram dosage, and that is because there's an amount of sodium bicarb in the medicine, and that's not good to get an extra dose of sodium bicarb if we don't need it. The IV pantoprazole, give over a 15-minute period. We need a dedicated line. We need to flush before and after with normal saline, D5W, or lactated ringers. It can be irritating to the veins, so we need to watch the IV site for that. IV esomeprazole, give over no less than 3 minutes, or we can infuse it for 10 to 30 minutes in a dedicated line, and that should be flushed with D5 or LR. Adverse effects of the medicines are nausea, vomiting, diarrhea, and headache, and abdominal pain. The omeprazole increases blood levels of some benzodiazepines, phenytoin, and warfarin, so we got to watch about that. Also, in your ATI book, it talks about these meds placing patients at a risk for pneumonia because it reduces that gastric acid secretion, and they can actually cause problems with the normal mechanism of the stomach, and thereby causing aspiration to occur. So, when we mess with the normal way the gut works and the normal pH, then we're placing people at risk. Also, long-term use can be a risk for gastric cancer and osteoporosis. So you have a pictogram again that you can read through. And it talks about the use of this for Helicobacter pylori or H. pylori. Then, needing to have follow-up with that, watching for signs and symptoms. Okay, and then some of our last medications that we're going to talk about are adjuvant medications. This is a prostaglandin, so you should know that is a hormone, and the medication for this is misoprostol, and it is a synthetic prostaglandin E, and it's used with NSAIDs to protect gastric mucosa. Now you may see this drug again coming up in your OB unit because it can produce uterine contractions. So it's contraindicated for the use of a decreasing gastric acid secretion in pregnant women because it can cause a miscarriage. It is specifically indicated for prevention of gastric ulcers caused by NSAIDs. Adverse effects are diarrhea, abdominal pain, nausea, vomiting, headache, vaginal bleeding, and uterine cramping. It should be taken with food at meal times and hours of sleep. And then sucralfate is a medication, another adjuvant medication. It is considered a mucosal protectant. This medication adheres to the ulcers to protect it from attack by acid, pepsin, and bile salts. So the dose is usually 1 gram 1 hour before meals and at bedtime. And since it does nothing to neutralize the stomach acid, the patient may also have antacids ordered along with it. To help with the acid part of it. Administer at least 1 hour before or after antacids and 2 hours before other drugs because it can mess with the absorption of other medicines. Now, the tablets for this medicine are huge. I call them horse pills. So if if the patient has a swallowing issue, then we can request a liquid form. It can cause constipation, so we need to encourage an increase in the fluid intake. And again, adverse effects with this are minor GI effects, nausea, constipation, diarrhea. Also, you might hear a patient report dry mouth. Okay, this concludes your podcast for this chapter.